This is kind of a follow-up. We had done a presentation last year, about 9 or 10 months ago, and we're excited to be invited back. So I'll briefly introduce myself. I'm Jason Kolb. Done emergency medicine for about 15 years, currently at Summa Health System, Akron City, and at satellite sites. In addition to emergency medicine, I did office-based opioid treatment for about 4 years, 1 or 2 days a week. And I loved it. And I don't do that any longer. I discontinued that when I joined Summa about a year ago, and I have an administrative role within Summa's emergency department to advance our ED-based MUOD program and to educate and just kind of be the champion. So with me today is Dr. David Seaberg. He's our department chair. He has been also a great champion and advocate for this program. And also Quentin Reuter, he's one of our core faculty members at Summa, has an interest and expertise in research. And so you'll hear from both of them. They'll jump in throughout the presentation, and then at the end, Quentin specifically will talk about some of our research ideas. So we'll get going. Good, so this is a slide of the Project Echo objectives. This is kind of the standard ones that we look at all the time, a little different format. I think that first bullet point and the third bullet point we'll definitely discuss today, especially that word collaborative. In the emergency department, this definitely is a collaborative effort, and we'll talk about that with our addiction care coordinators and our follow-up clinics. And bullet point number 3, we certainly recognize, and I know you all do as well, that these are very complex patients that need a lot of care coordination. And that, if anything, I think is the key to our successful program in Summa Emergency Department. This is our agenda for today. These are the 4 main things I'd like to discuss over the next 30 minutes or so. We'll review our emergency department guidelines for our MOUD process. We'll go over some updated data on visits, ED inductions, and follow-up. We'll briefly discuss our plans for expansion, and we'll finish up with our plans for research. So kind of under that first bullet point, there was 4 more bullet points that I wanted to talk about with our process. The first thing I wanted to discuss was our rationale for having kind of a formal process and guideline in the emergency department to initiate MOUD. And that may be obvious, you know, like it doesn't even need to be stated, but I think there's some interesting points that we'll get to. And we'll talk about how we identify the OUD patient in the emergency department. Again, that may seem obvious. Sometimes it is. Sometimes it's a little more subtle. And that's part of the education, is just educating providers on how to pick up the OUD patient who's there with a medical comorbidity or a psychiatric comorbidity. We'll spend a little time talking about our addiction care coordinator nurse and the peer recovery coaches in the emergency department. I don't think there's any single secret key to success of the program, but if there was one, this would be it. The addiction care coordinator is probably the main reason our program has been successful. He or she really does a lot of the work and the hands-on care. And then we'll talk about our referral process to long-term treatment. So the rationale for an ED-based MOUD program. This is where OUD patients come. They come to the ER, and they come for a variety of reasons. I have a whole slide dedicated to that, but it probably goes without saying that opiate dependent patients have a lot of barriers to accessing care. They have financial barriers, they have transportation barriers. So the ED is a very easy place for them to access, and consequently we see opiate use disorder patients all the time in the emergency department. So it's a natural place to identify them and discuss treatment option, and ideally start treatment in the emergency department. The second reason, and you all know this, is that opiate use disorder has a high mortality. I mentioned this study a few months ago during one of the sessions. This was from just a few months ago from the Annals of Emergency Medicine. This was a group from Wake Forest, and they studied 1-year mortality and associated factors in patients receiving out-of-hospital naloxone for presumed opioid overdose. And it was a very sobering study, as you can imagine. So we'll spend a little bit of time looking at that study and their results. The good news is that emergency department initiated treatment is effective, and we've known this for a number of years. This is kind of the landmark study that I cited here. This is from 2015. This was Dr. Gail Donofrio from Yale, and they were really the first to publish data on ED-initiated buprenorphine for opiate dependence, and they really show that it's effective for decreasing use and getting patients into treatment. So we'll also spend a little bit of time looking at that study.
So Jason, you know, this program's really talking about the treatment for opioid use disorder, but we are doing a lot of other work on really the front end in terms of our, you know, being measured on how many opioid prescriptions. We have alternatives to opioid use or opioid prescriptions. We have set up guidelines for prescribing. So we have worked, you know, also on the front end. You know, obviously we're talking about our opioid use treatment program, but we have in the emergency department, we're on that whole spectrum, and so we really have done a lot of work on both ends of this.
Yeah, and that's a good point, David. I think maybe in a communication today from our group talked about just highlighted our prescribing patterns and education where need be. I mean, it's a little controversial. You know, who's responsible for the opioid epidemic? Well, many of us in some ways. And how responsible is the emergency department for writing a script for 15 Norco for an ankle sprain? Well, we're learning that some of those patients transition to opiate dependence, sometimes because of our prescription. So Dr. Seaberg's absolutely right. We are working on the front end to decrease inappropriate use. We have some initiatives that we're working on to decrease opiate use in the emergency department for painful conditions. So for instance, IV lidocaine for kidney stones has good evidence to support efficacy and stuff like that. So yeah, we are working on both sides, and that's a good point, David. So we know that opiate-dependent patients come to the emergency department. How do we identify them? Many of them self-identify, and that's because of the reputation, particularly at one of our campuses at Barberton Community Hospital, where the program was initiated a couple years ago, before I even joined Summa, and it has a very good reputation in the community, including the community of opiate-dependent patients. They know they can come there. It's very well established. We have good relationship with one of the local judges in the community of Barberton, and he refers some of his defendants for treatment. He sometimes brings them down himself. And so a lot of times patients will come to the window and say, I'm here for my MAT treatment. So those are easy ones. Patients that are rescued with naloxone, especially pre-hospital, and they show up awake and often agitated, those are obviously obvious ones as well. Unfortunately, in my experience, these patients are generally not ready to discuss recovery. Occasionally they are. Then there's a lot of more subtle presentations. There's a lot of complications associated with opiate use and substance use. So for instance, skin abscesses, withdrawal symptoms. So sometimes patients will come in and say straight up, I'm in withdrawal. Sometimes they'll show up as intractable vomiting. And so this is kind of part of the education with all the providers in the ER to say, you know, have your radar up for this. If you got a patient who keeps bouncing back with intractable GI symptoms, Well, talk about cannabis hyperemesis, talk about opiate withdrawal. I have this patient ingrained in my mind from several years ago when I was at a different hospital, like 5 ED visits in 4 days, was admitted, had an upper endoscopy, had the whole workup, didn't get better until I asked him straight up, do you have a problem with opiates? And he acknowledged it, and we got him into recovery. It was really gratifying. So, other comorbid problems, endocarditis. I had a patient just yesterday, had multiple septic pulmonary emboli, almost certainly from endocarditis from use. And, unfortunately, he wasn't ready to discuss treatment and left against medical advice.
I'll say the incidence of all these complications has just skyrocketed over the last 5 years compared to, say, 10 years ago, where we hardly ever saw endocarditis or epidural abscesses, or rarely. And now you're seeing them, as Jason said, almost weekly in the emergency department.
And kind of getting back to that point on collaboration and complexity, Summa Health System has an endocarditis clinic that are dedicated to these patients. Endocarditis from any cause, but many of the patients have opiate use disorder or other IV drug use. And so there's just a lot of complexity and a lot of barriers there too. I mean, these patients often need a PICC line for 6 weeks or longer of IV antibiotics. And so you can just imagine the complexity and the temptation and PICC lines and so forth. Then we see a tremendous amount of psychiatric comorbidities. And it's my opinion, there's probably data, maybe Russell or Chris could confirm this, that a lot of patients with substance use disorder and opiate use disorder are self-medicating their severe anxiety or their depression or their past trauma or whatever. So a lot of these things are kind of interwoven and very complex. Patients that are suicidal after use and all sorts of things. So we see a wide variety of presentations of patients that have opiate use disorder. So I want to take a few minutes and dive a little deeper into this study that I cited. This is the one from the Annals of Emergency Medicine just a few months ago on 1-year mortality of patients that received Narcan pre-hospital. So this was a study from Wake Forest. It was a 2-year retrospective cohort in 7 counties in North Carolina. And the EMS systems there are all county specific, and that's how they were able to acquire all their data. Ultimately, there actually were about 4,000 patients initially. 3,000, just over 3,000 were enrolled in the study. A lot of the patients were disqualified because they were unfortunately cardiac arrest or DOA that may have received Narcan in what ended up being an unsuccessful resuscitation attempt. So about 25% were not in the final cohort, but they had just over 3,000 patients that were studied. What they found is that those who received naloxone and improved, so their clinical status and their mental status improved, 12% were dead 1 year later. And so the presumption is that if you improve with naloxone, then you obviously were suffering an opioid overdose. So that was a pretty sobering statistic. That's 1 in 8 or 1 in 9. And I mean, there's months when I see 10 or 15 of these patients in the course of a month, and to think that 1 or 2 of them is not going to be alive, that really kind of crystallized to me the severity of the mortality of this. So this did not study people who did not improve. That could be patients getting Narcan for sepsis or stroke or hypoglycemia or other conditions where the medics thought that Narcan would be appropriate. This is only those that improved with naloxone. And there's a lot of interesting data in the study. Just one thing I pulled out: older age and African-American race were associated with increased mortality. Multiple overdose patients were not. That was kind of surprising. So this is a serious problem. We all know that. That's just an interesting recent study from the emergency medicine literature. Oh, I would take a look at this slide again. I did use it last time. This is a chart from the kind of the landmark study 2015 out of Yale, really the first study that looked at ED initiated medication assisted treatment back then, what they called it. And I looked over the study again today just to refresh. It was really interesting. So they had 3 groups, and I probably didn't put these in the right order. So the referral group, I got the cursor right there. It's the center column. This group were identified as opiate dependent. They received a handout with a list of clinics and the telephone number and access to a telephone in the ER. That was the entirety of the intervention. And in fact, the assistants, the research assistants were instructed not to be encouraging or anything. This was kind of like quote unquote standard care. Unfortunately, and I've worked at times and in places where this was the standard care. Here's a piece of paper with some clinics. Goodbye and good luck. So there's about 100 of those patients. The referral and the brief intervention group, these patients received about a 10 to 15 minute brief negotiation interview. And then the research assistant assisted them in making follow-up, kind of went through the handout, said, what's your insurance? You could go here. Here's what this clinic offers. Help them actually schedule the follow-up and then provided or arranged for transportation. And then the study group is the buprenorphine group, which received all the above, the brief negotiation interview, the assistance with follow-up. In fact, these patients all received buprenorphine in the emergency department if they were in withdrawal. If they were not in withdrawal, apparently they were dispensed enough buprenorphine to self-induct at home and instructions on how to do that. And then all the intervention group, the buprenorphine group, they all had follow-up within 72 hours at the primary care clinic on the hospital campus. And they remained there for a couple months until they were then maybe transitioned to a true long-term, clinic in the community. So those that describes the 3 different groups, and, the retention rate and the opioid use days per week were statistically significant in the intervention group compared to the other 2. I will say this, prior to any of these 3 interventions, patients were using opioids 5 to 6 days a week. And I believe that was a self-report. I believe all of the use per days per week was self-report, but the follow-up at 30 days speaks for itself. So anyway, this kind of launched kind of an awakening in the emergency medicine community that, these are really sick patients and we can really make an impact and literally save lives. And so Summa developed their program a couple years ago. There's other programs across the country. Some are more aggressive with their dosing and things like that, but all of them are very similar. So we'll take a little deeper look at the role of our addiction care coordinator nurse. These are all nurses with interest and additional training in addiction care. Once a patient is identified by a provider, we'll ask for a consult from the nurse. He or she is there 12 hours a day at 2 of our campuses, Akron City Hospital and Barberton Community Hospital. They're there from 11 a.m. to 11 p.m. and they're dedicated to these patients. They don't care for the general ED population, only the substance use and opioid use patients that are identified. And so they'll do a brief negotiation interview. I'm not sure what the right terminology is there. They have a lot of time to spend with these patients. They'll calculate the COWS score. They will engage a peer recovery coach if the patient wishes. And the peer recovery coaches will physically come to the emergency department and spend time with these patients. So most of you probably know peer recovery coach is a previously substance use dependent patient person who has long track record of recovery, has some special training, and has an interest in reaching out and giving back to these patients, kind of like a sponsor for AA, I think would maybe be a good analogy. So these folks will come in, spend time with the patients. The addiction care nurse administers the buprenorphine that we order. They will dispense the Narcan to go, and then they'll spend time scheduling definitive follow-up. And we're fortunate within Summa Health System to have some good partners in the Department of Psychiatry and Family Medicine and others that take the vast majority of our patients, the vast majority within 3 days. When it can't be achieved for whatever reason, we have some trusted community partners outside of Summa that we refer to. So we've got really good community relationships, and we're almost able to always get these patients follow-up scheduled within 3 days.
We also, I mean, I don't know your next slide, but we also have most of our physicians now have their ex-DEA, and we'll occasionally write for several days. If we know that they're going to get into treatment, we do have that ability, which he'll talk about. But we've really worked hard to get most of our, or the majority of our physicians ex-DEA certified.
Yeah, and we're getting there. So yeah, that's well said, David. This is our protocol. This was a collaborative effort between the emergency department physicians, psychiatrists specializing in addiction recovery, and our PharmDs. And, you know, there's a lot of data here. I'll highlight a few things. It's a 3-day protocol because some of you may know that you can dispense or order buprenorphine from a hospital pharmacy to any patient without your X waiver. So for those of our providers that don't have the X waiver, they can still order this to be dispensed from the hospital pharmacy. So it's called the 72-hour rule, or the 3-day rule. Up top, everyone gets a medical exam. It's called the medical screening exam in emergency medicine. It's required by law. That happens every day, of course. Day one, our follow-up partners asked us to check some tests. So we check a comprehensive metabolic profile, mainly to look at liver enzymes, check an alcohol level, a urine drug screen, and a pregnancy test when appropriate. I put this benzo positive or methadone positive urine drug screen just to use caution. I think our understanding about co-use of benzodiazepines and buprenorphine is evolving to where it's probably not as worrisome as we once thought it would be, but you know, our collaborative team still is a little anxious about dosing when patients are benzo positive. So we've just educated the team to use caution, you know, to calculate their COW score, to clinically assess their level of withdrawal. If they're altered, lethargic from whatever, benzos, alcohol, sepsis, they're not appropriate to be dosed in the emergency department. But just because they dipped positive for benzodiazepines, but they're in florid opiate withdrawal, does not mean that we can't dose them. So that's been an area of education, and the team has really, I think, grasped that. This is our protocol. You know, it's a guideline. It's not rigid, but we start with 4 milligrams. Sometimes we start with 8. If we start with 4, we reassess them in an hour. Other protocols I've seen are a lot more aggressive on day one. Our collaborative team wished to stay at 8 milligrams. I believe it's because that's the label indication on buprenorphine. I have my own opinion on that. When we see patients day 2, we find out that 8 milligrams often did not adequately control their symptoms for that first day. And my fear, just my opinion, is that maybe we lose a couple patients in follow-up because they can't tolerate their withdrawal and they go use. But in any event, our protocol day 2 and day 3 allows for up to 16 milligrams. We don't necessarily do any testing on day 2 or 3. And so that's kind of it. And that's posted at all of our provider stations for reference. I got a couple slides on our data. at first glance, it's kind of overwhelming. All these numbers and bars, I'll walk us through it. We'll go left to right, top to bottom. SHB is Summa Hospital, Barberton. So again, this is the community hospital, about 90 to 100 visits a day. This is where the program was launched. The city of Barberton had a particularly severe opioid problem. And I will just tell you that I've worked and lived in the community for 20 years. Barberton Emergency Department for many years had a notorious reputation for dispensing a ton of narcotics. And that's changed in the past few years. And now Barberton has taken the lead in Summit County on treating the problem. So I'm really proud of that work that, you know, people started before I arrived on the scene. Let's go through all these lines. So this top blue line where I have the cursor, that is all substance use disorder patients per month. And I believe that's pulled off discharge diagnoses, and undoubtedly that underestimates the true number of patients, because sometimes patients will come in with agitation and we may not give them the diagnosis of methamphetamine abuse. The solid yellow line is opiate use disorder patients per month identified by discharge diagnosis. The solid blue bar is the number of addiction care coordinator nurse evaluations per month. And then right next to it, the light blue bar is the inductions. That means patients that were started on buprenorphine in the emergency department. So, you know, when I saw this data last month, this is about 9 months of data from September to June. There's a downward trend, very obvious. And, you know, I have a couple thoughts on that. I'll share them. I'd love to hear from some of the participants on this meeting, what your opinion is. So my first thought was, you know, maybe there's a seasonality to it. I have no idea. Is there a seasonality to opiate use whereby in the winter months, in the cold months, use goes down? Obviously, COVID has something to do with the decreased numbers because ED visits overall went way down. I think an optimistic opinion would be that patients are getting into treatment and staying in treatment, and that could be an explanation for why the numbers have trended down. A more pessimistic thought would be that patients have died and therefore no longer available for treatment. And undoubtedly there's some truth to that. I don't know. I know Chris is on and Russell. Is there a seasonality to substance use in your experience or in the literature?
Chris, you go first.
You know what? I think it's more anecdote than evidence-based. So, in fact, I would say that at least up north in Northeast Ohio, like, you know, Cleveland, winter is when all the units fill up, and summer is when everybody is out having, you know, parties and stuff. So it might even be sort of opposite. But like I said, I've not seen any literature to support a seasonality necessarily. I think the seasons are more related to what kind of drugs are getting shipped in from different countries and what kind of things are being put out on the streets by the dealers. That has more to do, I think, with the seasons than the actual weather. So that'd be my 2 cents on it.
Okay.
Yeah, that sounds good. I'm curious, Doctor. I think Dr. Ryan's on. In UCED in Hamilton County, are you noticing a similar trend, or?
Yes, we are. And what a great presentation. I'm going to be speaking about our program in a week, I think 2 weeks. So this is really fascinating to see this type of data. And yes, it is trending quite similarly.
Yeah, thank you, Dr. Ryan. Didn't mean to put you on the spot.
You know, I think with, I mean, you can see in April, our volume, but our volume dropped down in the emergency department overall about 47% across the country. I think you're seeing a leveling out. I think, we were up at 190 130 back in September of 2019, but then we opened up the city. So I think some of these patients that used to go to Barberton, you'll see in the next slide, I think have gone over to city. And so I think we're going to be probably averaging that 79 to 80, somewhere in the 70s from now on, just with that dip that happened across the country in April.
Yeah. The interesting thing to see how it's going to manifest is and this is more anecdotal, I don't think there's any really, there's certainly not a number of studies on it, but that there has been reported variety of ways that people are reporting increased distress through COVID-19. So there's more, calls to suicide hotlines. There's more calls asking about drug treatment. There's more reported people relapsing. So it'll be I guess we'll have to see how that manifests as things open up more.
Yeah. Yeah, thanks for that. Thanks for those comments from everyone. One last thing on the on the data on the left, just notice how close the blue line is and the yellow line. Excuse me, and we'll contrast that to the next slide at Akron City. On the right-hand side is a pie chart of patients that are inducted at Summa Hospital in Barberton. And don't get out your calculators. If you start calculating all these numbers between the pie graphs and then what's highlighted in yellow at the bottom, you're going to get some slightly different numbers. I did it. I think the take home here is that a large percentage of the patients at Summa Barberton Hospital that are clinically appropriate for induction with buprenorphine are in fact inducted. So down there, and this is Jamie McKinnon, our vice president of behavioral health for Summa, who collates all this data, and I'm completely indebted to him for all these slides on data. 88% of those who qualified were inducted, and only 12% of those who would have qualified declined. Now, you may be wondering, well, why are there some that are, what does not clinically appropriate mean? Often it means they're not in withdraw. So if they're not in withdraw, maybe they just used an hour before they showed up, using buprenorphine could put them into withdraw. And that is by far the most common reason that they're quote unquote not clinically appropriate. Another reason may be that they're intoxicated with alcohol or a variety of other reasons. This next slide is Akron City Emergency Department. Now, Akron City's volume is at least twice as great as Barberton's, just on a daily general patient population visit. What you'll see is a wide difference between the top blue line, which again is all substance use disorder visits, and the yellow line, which is opiate use disorder patients. And I think there's a couple reasons for this. So Summa Health System has a very active and well-known detox program. And so many of these substance use disorder patients that are recorded here are in fact alcohol dependent patients who come to the emergency department for medical evaluation and clearance to go to detox at St. Thomas Hospital, right? Akron, Ohio, St. Thomas Hospital. This is where AA was founded. So there's this well-known reputation for alcohol detox. So that's part of the explanation. Another part of the explanation is that we see a tremendous amount of methamphetamine at Akron City. And again, my guess is that these numbers here are underestimating the true number of substance use disorder patients that we see. I see so much methamphetamine. So the opiate use disorder is lower. The nurse evaluations, right, the addiction care coordinator evaluations is higher than the opiate use disorder patients. And that's because I'll often say to the nurse on duty, hey, this patient's struggling with methamphetamine dependence. They'd like to talk to somebody. Do you have some time? Because these nurses have the wonderful gift of time that the other providers often don't have, to sit and spend 30 minutes or longer at the bedside, and then get a recovery coach in who can spend 30 minutes or longer and talk about recovery and all sorts of stuff. You know, if you recall, the absolute numbers of inductions down here, the light blue line, is fewer than Barberton, even though we have twice as many patients daily at Akron City Hospital. You can see there's a lot of not clinically appropriate patients at Akron City. Two simple pie charts on follow-up. The left is Barberton follow-up, and the right is Akron City follow-up. Each one's about 75%. That's first visit. That's pretty good. And that's a compliment and a testimony to all the work that our addiction care nurses do, because they're the ones that do all the work, including getting these patients Uber or Lyft, or engaging the peer recovery coaches who often pick these patients up and take them to their appointment. What'll be interesting, and Quentin may comment on this, is our long-term follow-up. It's great to make it to that first appointment. I'd love to see him in treatment at a year. And so that's something Quentin may discuss at the end of our presentation, which we're very close to the end. I only have one slide on expansion. I thought, how can I make this more complex? It's not complex. It's really pretty simple. This is a schematic that shows the approximate size of the emergency department in terms of patients seen per day, and the approximate location of each emergency department of Summa Health System in Northeast Ohio. So Akron is the largest, just over 200 visits a day. Oh, I don't know, probably 8 or 10 miles away is Barberton at about 100 visits a day. Maybe 10 miles south of Akron City is Greene. It's a freestanding emergency department, about 50 to 60 visits a day. And then another maybe 10 miles west is Wadsworth, which is essentially a freestanding emergency department. Even though they're fairly close in proximity, they're miles apart in terms of patient population. Akron City is a very traditional urban inner city population. Barberton is, I don't know how to describe Barberton, probably a lower middle class community. Both of those are in Summit County. Greene is in Summit County, but it's very close to Stark County. Greene is definitely our wealthiest zip code, probably middle to upper middle class. And then Wadsworth is a very rural community, and it's actually in Medina County. So as we wish to expand our services to our other sites and to maybe capture patients in other counties, for instance, Medina County is very underserved for opiate treatment. Our plan is to use telemedicine and iPads and a HIPAA secure platform and leverage the addiction care coordinators that are already on duty at Akron City and Barberton, and as they can, do telemedicine consults with patients at the other facilities. Right before we started today, we were talking about, we had submitted a grant, and it sounds like we kind of had conditional approval, but there's problems with project management because of COVID and furloughs. So part of our funding, though, was for this very reason. And I hope we're able to move forward, just because I think it's a good use of the addiction care coordinator's time. And I think it'll be interesting to expand our program to our freestanding emergency departments. And then for our last few slides, I'll kind of turn it over to Quentin Reuter, who's done a lot of work and a lot of thinking about research that we'd like to do.
Thanks, Jason, and thanks for having me. As you're talking, I just wanted to quickly say, before mentioning the research stuff, just a comment about the clinical interaction with the MAT program as a physician on a day-to-day basis. And it's, as you're talking, it made me think before this, there's very little to offer these folks, and it's frustrating because as an ER doc, you want to fix things, and when someone comes in with a shooter's abscess or a withdrawal, you can kind of put a Band-Aid on the problem, but getting after the root cause of the patient's illness is always really frustrating and difficult to do. And with this program now, it's taken a relatively frustrating and negative interaction a lot of times as people become kind of callous to these patients and turned it into genuinely positive one where the patients are incredibly appreciative. And as a physician, you feel like you can offer something of substance that's, again, actually going to get at the root cause of their addiction and what they need. And so it's taken it's on me, and then I think our department had a big impact on just the way we approach these patients and helping to, establish that bridge of trust. And I remember, Jason, you mentioned this at one of our department meetings where, you had mentioned 600 patients at one point had gone through this, and you made the comment that 600 more people with opioid use disorder are now exposed to the idea of recovery. And certainly not all of them are going to stay in recovery long term, but it's a chronic illness. And again, I think building that bridge between the healthcare system and these patients is really important. I think this plays a big role in it. So yeah. Really quickly, just wanted to share with everyone our research plan moving forward and a little bit of what we've done. Earlier this year, we just published on, and Jason had mentioned, retention rates and retention outcomes for folks that we start on MAT. And we published earlier this year on like 1 and 2 month follow-up, which is relatively short, but I think showed somewhere around a 55% retention at 1 month and closer to 40% at 2 months, which is on par or a little bit better with other published literature in the same kind of area. And then currently working to collect 6 month and 12 month follow-up data, kind of answer the more pressing question of long-term, how are these folks doing? And then moving forward, certainly treatment retention is very important and key. We want to start looking at what effect are we having on these patients' lives, more so than just are they even plugged into just treatment, but starting to look at things like quality of life, depression, anxiety, suicidal ideation. And so starting relatively soon, we're going to start at intake, take baseline data on those areas, quality of life, psychiatric well-being, collecting data in a relatively structured manner to help evaluate our program and see if we have an impact on those characteristics long term at 6 and 12 months. And so it'll be done largely as a self-administered survey that patients will take. They're normally in the department 2 to 3 hours, getting their labs checked, getting the Suboxone, getting their withdrawal symptoms under control. And so while they're doing that, taking this intake survey, and then we'll follow up with them, like I mentioned, at 6 and 12 months to see if we're having an effect on those quality of life and psychiatric markers of health. So that's one area. Also, as mentioned, the expansion into telemedicine, we want to take a look at and see how effective telemedicine is as compared to in-person induction on the buprenorphine. And so we'll definitely look into that, taking a look at both retention rates and then, again, quality of life metrics and seeing if there's a difference or enhancement, whether it's in-person or telemedicine. And then finally, hopefully in the near future, we'll be doing some focus group data collection and really trying to get at the heart of what these patients need, what we do well, what we need to do better, help facilitate their recovery, and hopefully generating other research hypotheses and ideas for how to improve our program moving forward. So that's a brief overview. And Dr. Seaberg, if you have other stuff to add, please jump in, or if anyone has questions.
Yeah, no, I think that's a really good summary, Quinn. And, I think retention rates is a bit of a crude metric. It's an important metric, but we're going to start looking at health-related quality of life measures, looking at their mental health, social, physical functioning. We're going to also look at using different surveys to assess that and even find out which surveys may predict better retention rates or better improvement. So we're going to be looking at that. And as Quinn also mentioned, social determinants of health, transportation, other aspects that might be affecting either retention rate or recovery. So we look to have this as a major focus in our department over the next several years. We've applied for some funding. There's an R21 out right now that we're going to be applying for to look to try to get some funding, because I think this is an area that's very important. I think we've got a very successful program that needs to be just better evaluated.
wow. In the South, when we're impressed, we say dang. So